you have issues that are global, cognitive, whatever, these are the ones I think are probably most likely going to respond to removal of the venous obstruction. If you have already neurogenic disease with focal loci that are creating symptoms, just because your veins get improved, that demyelination is not going to spontaneously remyelinate. It's not like all of a sudden those changes. Having said that, there are clearly many patients who've had strength improvements. The other day, one of my fellows basically said this, treated this patient, and he came into the recovery room, and the patient was just beaming because she had opened a potato chip bag. Now, you know what it's like to open a potato chip bag. You kind of got to grab it and kind of pop it up. Just couldn't, 10 years, not enough strength to open a potato chip bag, and she just went, opened it right up. I'm convinced that there's some relationship between CCSVI and chronic fatigue syndrome, which again is another one of these EV virus implicated deals. I've seen a number of patients now who don't have MS and don't have what I would consider significant brain disease, little things that could be anything for that matter, but are completely incapacitated by fatigue and other things. And when we did their MRVs, and flows like that, they're big time abnormalities. So that's one for sure. I don't know. Suffice to say, certainly there are people, non-MS patients, who have CCSVI. And there are MS patients who don't have CCSVI. Does that bother me? Not in the slightest. It bothers a lot of people and a lot of neurologists who think sort of that how can you possibly have CCSVI and not have MS if that's the cause of MS? I'm not saying it's the cause. Never said it's the cause. Again, I think it's a factor, one of many factors that functionally come into play in each person's individual mosaic that has led them to get the disease. Side effects, well, I think right now it's kind of evolved, and we know a lot more than we did about the risks, and I think that in general, dilating the venous valve area is pretty risk-free. It's nothing, suffice to say, anything can happen. Let's leave it at that. But as things go, as you well know, this is an outpatient procedure for the most part. And so you go home right away. So I'd say right now, the state of our experience, it tends to indicate that this is a relatively safe procedure, and I think only more experience in prospective controlled studies will document that. So, but it's not, on the grand scheme of things, it's pretty benign therapy. Well, venous stents we have a lot of experience with, and the ones that tend to migrate, and the reason they migrate, their stents were made for arteries in the most part. There's no stent approved for use in any venous application now. But since they're made in arteries, and arteries are like trees, they successively get smaller and sort of pruned down, or basically the arteries go from larger to bigger, and so they're not going to move. But when you get to veins, the veins go from smaller to bigger in the direction of flow. So they're a reverse taper, so there's always this chance you're kind of sticking a cork in something and hopefully it'll stay. Now, what's the big deal? With self-expanding stents, I would always put in stents that were a little bigger than the vessel, and that would anchor them there. No big deal. Our problem was that in the ones that are high, as you showed those kinks that we talked about, the accessory nerve, which is cranial nerve 11, runs in that jugular sheath at that level up high. So when we would oversize, even by a millimeter or two, patients would start to not be able to get shoulder symptoms. And although almost everyone eventually resolved, it took not days or weeks, but it could take months for it to get better. Certainly by 6 months, they were dramatically better. Some people still have little twinge, but this could be anywhere from I can't raise my shoulder all the way to it kind of hurts when I try and do this, to it feels like my arm's falling out of its socket type stuff, you know. And so that led us, of course, to be less aggressive with oversizing. Unfortunately, that puts us at higher risk for migration or location. And if it happens, it's going to happen very soon. It's not going to happen. So people are always worried. I've got this sort of time bomb that is, you know, after 5 weeks out, that these things happen within the first 48 hours. Okay, who's going to migrate? After that, it's pretty sure it's not going to migrate. I will tell you, and again, I don't have an answer for you, and I've gotten very good at saying I don't know, but I will tell you that patients who have the most, the least progressive disease, the less symptoms, seem to kind of benefit the most in terms of actually potentially becoming rather asymptomatic, and that's in the short term, not in the long term, because we don't have long term. The reason, because they don't have all this pre-existing demyelination and neurogenic injury. Can I say it's absolutely foolproof, risk-free? No. But I can tell you that it's not, in my mind, completely wacky to be thinking like you're thinking, because you have a potential to potentially not, or at least remove one of these things that could influence your trajectory of disease at a time when you're not really that effective. I think all of us who've treated patients, and there's some in the front row have, and there's some patients who've been treated also, fully believe in their heart of hearts that there's something here that's more than placebo. There are many reasons for that. Here's a practical one. Patients get treated, they feel better. They also, after some period of time, the symptoms come back. They get studied, clearly restenosis. They get treated, they feel better again. Come back, and it's restenosis. Everyone's aware of these type of patients. The other thing that for me, before these patients became more obvious, were things like nocturnal enuresis, people having to get up and go to the bathroom 9 times a night, 8, 7 times a night, getting up maybe once or twice. Is that zero? Not necessarily, but it's remarkably different. Other things are headaches, and headaches in MS is not, you know, the most common thing, but it does occur. And I've had many patients who've said, after they've been treated, their headaches went away. They say, I defy any neurologist telling me that I can will my headache away, that I could, on demand, will my headache away. I've had it every day for blah, 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 and now I don't have it. That's one thing. And then finally, I had this patient from Monterey who's just a good old guy, and he called me one day and he said, you know, I won't believe what happened. We live in this 2-story house, and and I walked downstairs to make breakfast, and I was having the toast in, and all of a sudden I thought, I walked down the stairs without holding the banister. That's never happened in 10 years. You know? And, you know, these are all these kind of anecdotal testimonials, but I think most of us, having heard these things, are sort of convinced there's really something here. And I don't think anyone's trying to say, this is the cause of MS, and, you know, it's the end-all, be-all, and, you know, you can throw your crutches away and all that stuff. No, but clearly there's something going on.